Hello everyone and welcome to our module on pericardial disease. The pericardium is the sac that surrounds the heart inside the chest, and it's made up of three layers. The outermost layer is called the fibrous pericardium. The inner two layers are collectively called the serous pericardium. The serous pericardium has two sublayers. One's called the parietal layer and one's called the visceral layer. The visceral layer is what surrounds the heart. Between these two layers, the parietal and visceral layers of the serous pericardium, is what's known as the pericardial cavity, and as we'll discuss later, this is the portion of the pericardium that fills with fluid in pericardial effusions and tamponade. The pericardium receives its sensory innervation from the phrenic nerve, and this is important because sometimes patients with pericardial injury like pericarditis can have referred pain to the shoulder, and that's because the phrenic nerve has common nerve roots with nerves that innervate the shoulder as well. There are three pericardial diseases you need to know for step one: pericarditis, tamponade, and constrictive pericarditis. We'll go through all these in the next few slides. Pericarditis is the most common pericardial disorder, and as the name implies, it involves inflammation of the pericardium. This is an autoimmune process. It's an immune-mediated attack on the pericardium. The triggers and the details are poorly understood, and in some cases after treatment pericarditis recurs, and this is obviously called recurrent pericarditis. Pericarditis is usually benign, and the most important thing to do with pericarditis is distinguish it from coronary disease and other serious cardiovascular disorders. So you need to understand the symptoms of pericarditis. So the major symptom of pericarditis is chest pain, and it has very unique features that are different from ischemia. The chest pain of pericarditis is usually sharp. It's worse with a deep breath. This is called pleuritic pain. It's worse when patients lie flat, which is supine, and it's better when they sit up or lean forward. And all of these features are usually not seen in coronary disease. In addition, because this is an inflammatory condition, you may see fever or elevated white blood cell count or an increased erythrocyte sedimentation rate, all signs of systemic inflammation. Shown on the screen is an EKG demonstrating all the classic findings of pericarditis. When you first look at this ECG, you might think that there are ST elevations caused by ischemia. For example, this is the baseline ST segment in lead 2, and there's ST elevation seen here. You can also see some ST elevations here in lead V2. These ST segments are elevated. You can also see some ST segment elevations in other leads like F and 3. So basically what you see on this ECG are ST elevations in multiple different leads. Classically in pericarditis, you can see ST elevations in every single lead, and that's what differentiates it from ischemia. In ischemia, the ST elevations are localized to one area of the heart, like the anterior wall or the inferior wall. I've zoomed in on lead 2 here so I can show you the other classic finding of pericarditis, which is PR segment depression. The PR segment is the segment from the beginning of the P wave to the start of the QRS complex. And notice that this PR segment is going at a downward angle. That is PR depression, a classic finding in pericarditis. So the two classic findings are diffuse ST segment elevations in multiple leads and PR depression. Technically, there are 4 stages of EKG changes in pericarditis. Stage 1 is the first stage, and this is what I'm talking about in the last slide: diffuse ST elevations and PR depressions. About a week or so later, the ECG will look normal, and about a week or a few days after that, the ECG can develop T-wave inversions, and then it can go back to normal again. So what you need to understand is that sometimes you can see T-wave inversions in a person who had pericarditis a few weeks ago, and that's actually a normal progression of changes, not a sign of a new heart condition. The classic physical exam finding in pericarditis is called a pericardial friction rub. This is a scratchy sound. It's often described as sandpaper rubbing together, and it's heard throughout the cardiac cycle in systole and diastole. And I'll play an example of that for you now. There are a number of potential etiologies for pericarditis. Most cases are idiopathic with no clear cause determined. In this situation, we usually presume it's viral, but we don't have a definite diagnosis of the virus that caused the condition. Viral pericarditis is also common. The classic virus to cause this is Coxsackie virus. Often the pericarditis follows an upper respiratory tract infection, so the patient has a cough and a sore throat, and a week or two later develops pericarditis. That's a classic history of a patient with viral pericarditis, most likely from Coxsackie virus. Bacterial pericarditis can occur. This can be due to spread of pneumonia to the pericardium. It also may be seen after cardiac surgery if bacteria are introduced into the pericardium. And then finally, tuberculosis in some cases can spread to the pericardium. There are also cases that have been reported of fungal pericarditis as well. When patients develop uremia from renal failure, they often develop pericardial inflammation. This is called uremic pericarditis. There are two forms of post-myocardial infarction pericarditis. One's called fibrinous, which occurs days after an infarction. The other is called Dressler's syndrome, which occurs weeks after infarction. And I talk about both of these in the video on cardiac ischemia. And then finally, patients with autoimmune diseases like rheumatoid arthritis or lupus often develop autoimmune pericarditis as a complication of their condition. The treatment is very straightforward. The mainstay of treatment is nonsteroidal anti-inflammatory drugs like ibuprofen. Steroids can be used in some cases. And then finally, colchicine is a special medicine that is used in pericarditis. It inhibits white blood cell action via a complex mechanism that's not well understood. Colchicine basically has three niche uses. One of them is pericarditis. It's also effective in gout, and it's also effective in the rare condition familial Mediterranean fever. And we usually add this to nonsteroidal anti-inflammatory drugs to treat pericarditis and lower the risk of recurrent pericarditis. Myopericarditis is the term we use to refer to myocarditis that occurs together with pericarditis. Sometimes the two conditions occur at the same time. Myocarditis is inflammation of the myocardium. It has a similar presentation to ischemia, including chest pain, ischemic EKG changes, and elevations of cardiac biomarkers. Some patients with pericarditis also have ischemic EKG changes and biomarker elevations, and we say that those patients have myopericarditis. Our next pericardial disorder is tamponade. In tamponade, there is an accumulation of fluid in the pericardial sac, and that fluid develops a very high pressure, so high that it restricts filling of the cardiac chambers. Now, you might think that it would require a massive amount of fluid to cause a high pressure and restrict filling, but it turns out that the amount of fluid found among patients with tamponade is variable. If the fluid accumulates rapidly, as occurs in trauma and bleeding, then just a small amount of fluid can lead to tamponade. The reason for this is because the pericardium needs time to stretch, and when the pericardial sac fills with fluid quickly, there's no time for stretching and the pressure gets very high even with a small amount of fluid. On the other hand, if the accumulation is chronic and slow, as happens in cancer patients, then the pericardium has time to stretch, and therefore a large amount of fluid is required before the pressures get high and restrict filling of the cardiac chambers. This is an echocardiogram image of a patient with tamponade. This is the LV cavity right here. This is the wall of the left ventricle. This is the RV cavity here. And this black space surrounding the heart is fluid. And when that fluid takes on a high pressure, that can lead to tamponade. The water bottle sign is the classic chest x-ray finding of a pericardial effusion. The heart becomes enlarged and looks like a water bottle. This is a non-specific finding. You can see an enlarged heart like this in many conditions, but this is what's seen in a pericardial effusion in tamponade. There are many causes of tamponade. Cancer patients often develop this condition because of metastases to the pericardium. That leads to fluid accumulation. Patients who are uremic, I told you before, can develop pericarditis. They may also develop pericardial effusions leading to tamponade. And in fact, any cause of pericarditis can potentially be complicated by an effusion and tamponade. And then finally, as I told you before, trauma can lead to bleeding in the pericardial space, which can rapidly build up a high pressure and cause tamponade. And the treatment of tamponade, no matter what the cause, is to drain the effusion to relieve the high pressure in the pericardial sac. On this slide, I've listed the clinical features of tamponade. The heart sounds will be distant. When you examine the patient with the stethoscope, there is a wall of fluid surrounding the heart, so the heart sounds are distant. Patients classically develop dyspnea very early on. This is because the pressure in the left atrium becomes high and pulmonary edema may occur. And then finally, the jugular venous pressure may also be elevated when you examine the neck. That's because the right atrium cannot fill normally, and the pressure in the right atrium is also becoming elevated. Beck's triad is a collection of three clinical findings that can be seen in tamponade. Those three findings are distant heart sounds, elevated jugular venous pressure, and hypotension. Beck's triad is usually only seen in trauma. You need to have a rapidly developing, usually traumatic effusion for this to occur. Remember that the pericardium does not have time to stretch in the setting of trauma, and therefore just a small amount of fluid raises the pressure in the pericardial sac significantly. This can lead to a severe impairment of LV function, so severe that the cardiac output drops and hypotension occurs. In slower developing effusions, like the kind that develop in cancer patients, the pericardium has time to stretch and dilate, and therefore you usually do not see Beck's triad. Instead, you only see dyspnea and signs like distant heart sounds and elevated JVP. Pulsus paradoxus is a change in blood pressure that occurs in tamponade. It is a classic finding of tamponade. In order to understand pulsus paradoxus, you need to understand that our systolic blood pressure always falls slightly when we take in a breath or inspire. In tamponade, there is an exaggerated fall greater than 10 millimeters of mercury, and this is called a pulsus paradoxus. It gets its name because if the tamponade is severe, the drop in blood pressure can be so great that you can no longer palpate the pulse. So hundreds of years ago, doctors noticed that patients with fluid around their heart would have their pulse disappear when they took in a deep breath, and they called that pulsus paradoxus. The physiology of pulsus paradoxus is shown on this slide. Anytime you inspire, you increase the venous return. This is the reason that right-sided heart murmurs like tricuspid regurgitation get louder during inspiration. This will increase the right ventricular size, but in the setting of tamponade, the right ventricle, if this is the right ventricle here, is surrounded by a high pressure fluid accumulation. This means that the right ventricle cannot distend outward as it normally does, so instead all the distension goes into the wall between the right ventricle and the left ventricle. That means the septum between the two ventricles bulges into the left ventricle. This shrinks the left ventricular size, and that drops the cardiac output, and that's why the blood pressure falls with inspiration. If it's severe, the cardiac output can get so low the pulse disappears. Usually it's not that severe, but if you examine the patient, you can measure the blood pressure change with inspiration, and you'll find a drop of more than 10 millimeters, and that is diagnostic of pulsus paradoxus. The normal drop is always less than 10 millimeters. It's high yield for your boards to know that a pulsus paradoxus can be seen in lung diseases like asthma and COPD. The physiology behind pulsus paradoxus in these conditions is very different from the physiology in tamponade. Normally when you inspire, there is a slight decrease in left-sided flow. This is why murmurs on the left side of the heart like mitral regurgitation get quieter during inspiration. The reason for this change in left-sided flow is pulmonary pressure fluctuation that normally occurs when you take in a breath. These fluctuations in pulmonary pressure are exaggerated in lung disease. So for example, in a normal patient, the pulmonary pressures only change from about 0 to minus 5 millimeters when you take in a breath. In patients with lung diseases, the change can be up to 40 millimeters, and for this reason, there can be a large drop in left-sided flow, and this leads to pulsus paradoxus, the same finding you see in tamponade, but via a totally different mechanism. Shown on this slide is the measurement technique to obtain a pulsus paradoxus from a patient at the bedside. This probably won't come up on the step 1 exam, but med students are often asked to do this on clinical rotations, and it can be embarrassing if you know how to interpret a pulsus paradoxus but not how to measure one at the bedside. You begin by putting the blood pressure cuff on the patient the way you normally would to measure the blood pressure and placing your stethoscope in the antecubital fossa in the normal fashion. You then raise the cuff pressure until you hear no Korsakoff sounds. Importantly, the patient should be breathing normally. Do not ask the patient to take in a deep breath or do anything unusual. Their respiratory pattern should be completely normal. You then slowly lower the cuff pressure. So let's imagine, for example, you pump the blood pressure cuff up to 150 millimeters and you hear no Korsakoff sounds. You then slowly let the pressure come down, and let's say you get to 130 millimeters and you begin to hear intermittent heart sounds. You will hear a bump, bump, and then no sounds, and then a bump, bump. What's happening here is that you are hearing sounds only during certain parts of the respiratory cycle. You then continue to lower the blood pressure cuff, and let's say you get down to 125, and you will hear Korsakoff sounds throughout the respiratory cycle, so bump, 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 bump. The difference between these 2 points, 125 and 130, is the pulsus paradoxus. That's how you do it at the bedside with the patient breathing normally and identifying the point where you hear intermittent sounds and where you hear constant sounds. There are some EKG findings that may be seen in tamponade. Most patients have sinus tachycardia. You may also see low voltage of the QRS complexes. The EKG sees less electricity due to the effusion around the heart, and therefore instead of having a big tall QRS complex, you may have a small QRS complex. That's called low voltage. And then finally, some patients have a heart that is swinging inside the pericardial effusion. They will develop an EKG finding called electrical alternans. This is when some QRS complexes are bigger and others are smaller in an alternating pattern. Basically, the heart is swinging inside the effusion with each heartbeat, and that creates electrical alternans. In another video, I talk about venous pressure tracings and all the normal findings, including the A wave and the V wave. You should be aware that there are 2 classic venous pressure tracings seen in tamponade. They are called a prominent X descent and a blunted Y descent. The X descent is right here. It's the fall in pressure after the A wave caused by relaxation of the right atrium. The Y descent is right here. It's the fall in pressure after the V wave caused by filling of the right ventricle from the right atrium. Basically, blood is leaving the right atrium for the right ventricle, and that causes the pressure to fall. In tamponade, there is a prominent X descent, and this is caused by a change in the fluid surrounding the heart. To understand this, let's draw a right ventricular cavity, and we have the tricuspid valve here, and above the right ventricle we have the right atrium. In tamponade, there is a fluid collection surrounding both chambers. When the right ventricle contracts, these walls move inward. This allows some of the fluid surrounding the right atrium to move down in the pericardial cavity. This makes it very easy for the right atrium to relax, and thus there is very vigorous relaxation of the right atrium. Remember, relaxation of the right atrium is what causes the X descent. So instead of getting a normal gentle fall in pressure like you would see in the right atrium for a normal X descent, you get a much deeper and more prominent X descent in patients with tamponade. And I've summarized these points here. There's a deep fall in RA pressure during right ventricular contraction in systole. Remember, systole occurs between the C wave and the V wave. That's when the right ventricle is contracting, and you get a very deep and prominent X descent in patients with tamponade. The other finding in tamponade is a blunting of the Y descent. So the Y descent, shown right here on the normal tracing, is caused by blood leaving the right atrium for the right ventricle. And there's poor RV filling in diastole in patients with tamponade, and therefore the Y descent is blunted. So what you see in patients with tamponade is something that I've shown on the bottom of the screen here. You've got a very prominent X descent here and a very flat or blunted Y descent. Besides all those findings in the venous pressure tracing, there is another classic finding of tamponade that you can see when you measure the pressure in all the chambers in the heart. This finding is called equalization of pressures. This is what you see when the cardiac chambers cannot relax. What you see is that the pressure in the right atrium, right ventricle, left atrium, and left ventricle fall, but then abruptly stop at some high level. You see this finding, equalization of pressures, in both tamponade and in pericardial constriction, which we'll talk about in a minute. So let's take a look at what I've drawn in this table on the screen here. So a normal right atrial mean pressure is about 5. A normal right ventricular pressure is 20/5. And a normal pulmonary capillary wedge pressure, which is a marker of left atrial pressure, is about 10. In tamponade, what you see is that, first of all the pressures are high, and that should make sense to you. This patient's heart is surrounded by fluid, so all the pressures are high. But you also see something else. There is equalization of pressures. The mean RA pressure is the same as the RV diastolic pressure and the wedge pressure. This is not a normal finding. This is called equalization of pressures, and this is what occurs in tamponade. To understand this, let's imagine we've got the right atrium here, and it is relaxing, so the walls are moving outward in this direction, and the pressure in the right atrium starts to fall. But as soon as it gets to 20, it can't fall any further in tamponade. Why is that? That's because there's fluid surrounding the right atrium, and the pressure of that fluid is 20, so the right atrium can never get below that pressure. And the same thing is also true in the left atrium and in the left ventricle during diastole. The bottom pressures for all those chambers are being dictated by the pressure in the pericardial sac, not by what's going on with the myocardium and relaxation. Our last pericardial disease is constrictive pericarditis. In this condition, there is a fibrous calcified scar in the pericardium, and as a result, the pericardium loses its elasticity. It becomes stiff, thickened, and sticky. And this can result from many pericardial disease processes. So patients who have had pericarditis once can later develop constrictive pericarditis. Patients who have had chest radiation to treat malignancy can develop constrictive pericarditis. And any patient that's had heart surgery and had their pericardium damaged during the operation can also develop constrictive pericarditis. Here's an example of an X-ray from a patient with constrictive pericarditis. Note that there are these white lines in the pericardium surrounding the heart. That is evidence of calcification of the pericardium, and that's one of the hallmarks of constrictive pericarditis. The main complaint that patients with constrictive pericarditis have is dyspnea, and you should be aware that on exam, right heart failure symptoms predominate. The right ventricle is the most impacted by that calcified pericardium surrounding the heart. So these patients often have signs and symptoms of right heart failure. This includes elevated jugular venous pressure, lower extremity edema, and even congestion of the liver that can sometimes lead to cirrhosis. When the liver becomes cirrhotic from heart failure, that's called nutmeg liver, and this is a picture of a nutmeg to remind you of that on the screen. And one thing you need to be aware of is sometimes patients with constrictive pericarditis look like patients with cirrhosis. They can have a swollen abdomen with ascites and lower extremity edema. You want to very carefully examine the neck because the jugular venous pressure should not be increased in cirrhosis of the liver. If you see someone you think has liver disease but the JVP is elevated, that patient may actually have constrictive pericarditis. Pulsus paradoxus is rarely seen in constrictive pericarditis. Only about 20% of patients have pulsus. The reasons for this are unclear. All of the pressures in the heart are elevated, just like in tamponade. You can also see equalization of pressures, just like in tamponade. And there is a clinical finding on auscultation of the heart that is rarely heard. It's called a pericardial knock. It's a diastolic heart sound just after S2. It can often sound a lot like an S3. Kussmaul's sign is a classic finding in pericardial constriction. So when you take in a breath, as we talked about before, that raises the venous return to the right heart. And normally there is a slight fall in the mean jugular venous pressure. And you can actually see this if you examine the neck of normal patients. You can see the jugular venous pressure fall when they take in a breath of air. Kussmaul's sign is when the opposite occurs. The jugular venous pressure rises with inspiration. This is abnormal. And this happens in pericardial constriction because the ventricle cannot accept the increase in venous return. The right ventricle is surrounded by a calcified sac and it can't expand to accept the venous return, so instead the pressure in the right atrium rises, and you can see that when you examine the neck. This is seen in constrictive pericarditis. It's also seen in restrictive cardiomyopathy, and you can rarely see this in a right ventricular myocardial infarction. It is not seen in cardiac tamponade. When I was a medical student, I had a lot of trouble keeping pulsus paradoxus and Kussmaul's sign straight, so I've got some tips for that in this slide. Pulsus paradoxus is the classic sign of tamponade, and you can remember that you see a pulsus in tamponade. The P is for pulsus. Kussmaul's sign is the classic sign of pericardial constriction. It's also seen in restrictive heart disease, so you can remember that you see Kussmaul's sign in constriction restriction. And I've made a table on the bottom of the screen summarizing pulsus and Kussmaul's. You see pulsus in tamponade, but usually not in constriction or restriction. You see Kussmaul's in constriction and restriction, but usually not in tamponade. There's a classic venous pressure tracing finding in constrictive pericarditis. It's called a rapid or prominent Y descent. Remember that the Y descent is the fall in pressure after the V wave. It's caused by filling of the right ventricle. In patients who have constrictive pericarditis, this becomes very rapid and prominent. It looks like this, and there are two reasons for this. So let's imagine that we have a right ventricle, and then we've got the tricuspid valve, and then above the right ventricle we have the right atrium. In diastole, the right ventricular walls move outward. This draws blood in from the right atrium, and that causes the Y descent. Well, in pericardial constriction, the walls of the right ventricle are stuck and adherent to the pericardium. So in diastole, they snap very rapidly outwards, and this causes the Y descent to be very deep and sudden and abrupt. Then suddenly the right ventricle cannot fill anymore because there's a constriction surrounding it due to that calcified pericardium. This makes the pressure in the right atrium suddenly go right back up, and the result is that you get a prominent Y descent. And I've summarized these points here. There's rapid filling of the right ventricle with an abrupt stop and filling. The myocardium of the right ventricle is adherent to the pericardium, so in diastole there's rapid relaxation and suction of RA volume. This causes the Y descent to be very prominent or rapid. On this slide, I've summarized some of the key venous pressure findings in patients with pericardial disease. So in tamponade, the X descent is rapid and the Y descent is blunted or absent. In pericardial constriction, the major finding is a rapid or prominent Y descent. Another classic hemodynamic finding of constrictive pericarditis is called the dip and plateau, or the square root sign. When you measure the pressure in the right ventricle of a normal patient, you see a tracing like what I've drawn on the screen here. So the pressure rises to a value of about 24 millimeters or so, and then it falls and comes up to a pressure at the end of diastole of about 5 millimeters or so. And this is what you see in a normal patient. In a patient with constrictive pericarditis, you see what I've shown on the right side of the screen here. So it has what's called the dip and plateau. You can see that there's a very deep dip here in the right ventricular pressure tracing, and then the pressure begins to rise but abruptly stops and then plateaus. This is also sometimes called the square root sign because it looks like a square root. And the physiology here is the same as the physiology we talked about before in the venous pressure tracing. There's rapid filling of the right ventricle because the myocardium is adherent to the pericardium, and then there's an abrupt stop in filling because there is a calcified pericardium surrounding the right ventricle, and this gives you the dip and plateau, or the square root sign. I'll finish with this slide and mention that pericardial constriction and restrictive cardiomyopathy share many common features, and in clinical practice, telling the two conditions apart is very difficult. Luckily, they're both very rare. They're not going to ask you to tell them apart on the Step 1 exam, but if you know that they share many common features, it's easy to recognize them in board questions. So both conditions have prominent right heart failure symptoms like jugular venous pressure elevation and lower extremity edema and dyspnea. You can see Kussmaul's sign in both conditions. You can see a rapid Y descent on the jugular venous pressure tracing in both conditions, and you can see a dip and plateau in the right ventricular pressure tracing. All of these are common to both pericardial constriction and restrictive heart disease. And that concludes our video on pericardial diseases.